Hi, everyone. Welcome back to From Print to Pod. We have with us today a returning Dr. Stephen Cohen, and he wrote Sued Not Shamed: What Five Malpractice Lawsuits Taught Me About Being a Good Doctor. And we are going to dive into things, but why don't you just really quickly introduce yourself to those who have not yet met you?
So my name is Stephen Cohen. I have now been in practice for 32 years, board certified in both general and colon and rectal surgery. Currently still in active practice, teaching, training, educating medical students and residents here in Richmond, Virginia. Also busy doing other things, medical legal work that I've been doing for a long time. But this was an important article that I wanted to get out there.
Okay, fantastic. So let's get right to it so we could get to as many questions as possible within that 15-minute mark that we want to cover in this episode. So you reflect that your identity as a surgeon was reshaped and not shattered by litigation. How did navigating those five lawsuits alter your sense of professional self?
Well, anybody that's in this profession, as we take pride in what we do, and we always do the best that we possibly can based on the situation. When you get named in a lawsuit, the first thing you start to question is, do I even know what I'm doing? Right? I mean, it doesn't matter because you have very aggressive people on the other side telling you that you are the worst person in the world. And we don't get up every day to cause harm to patients, but that's what it makes the process makes it seem like we are there to harm people.
Yes, and I think that a lot of people, the article really resonated with them. I don't think that we talk enough about litigation. And so I think that that in particular is why your article stands out so much. You emphasize transparency and owning mistakes. Was there a turning point where you consciously shifted from silence to speaking openly, and what enabled that change?
Well, so I've also been part of peer review in all the hospitals I've been in for the last 30 years. So, peer review, as everybody knows, it's any complication that happens in the hospital, whether it's preventable complication, not preventable complication, we discuss it. And we don't do it in the hospital setting to be punitive, right? Is there a process issue? Did something fall through the cracks? Did there's some laboratory test that was supposed to be called to us? It wasn't. So I think being transparent, not only amongst the team taking care of the patient, with the family is important. There's a lot of articles out there that talks about preventing lawsuits that if there's a mistake, talking to the family, owning up to it, apologizing, that goes a long way in the prevention of lawsuits. It's not perfect. Remember, the most common driver of the lawsuit is not the patient you're taking care of. It's not the patient. It's not the patient. It's the family member. It's the relative. It's somebody who may be involved in medicine that thinks that they should get some money out of it, but it's not commonly the patient. The patients in general don't want to sue their doctor. But because there's a 2-year statute of limitations, once you have a complication, they may be over it, but they may wind up with a colostomy that they didn't want. They may wind up with a ureter injury that requires multiple surgeries down the line. You get out to the 1 year, the 2 year mark, that's when things start to fall apart. And I think I will tell you that the first lawsuit is the hardest because you really start to question, what did I do? Right? You don't go into to either ordering a test or doing surgery on a patient thinking you're going to do harm. Okay. We all get complications. There's only two kinds of surgeons that say they never have a complication. Either they're not operating or they're lying. There's no option. We get urinary infections and pulmonary embolus and wound infections. It's part of the game, right? Patients want a guarantee in surgery, especially. There is no guarantee in medicine. The other thing that I think I've learned along the way is I'm a lot less confident. I mean, I'm confident, but I'm a lot less confident when I'm talking to the patient about all the potential complications. I used early on, you'll be fine, you'll be okay, we'll get you through this, right? I kind of brush that off. I don't brush that off anymore. Look, there's you could die from this operation. This is elective surgery. You don't need this operation, especially something like a colostomy closure, which can have a lot of complications. They can live with a colostomy, right? So the first case is usually the hardest. You've never been involved in this situation before. Talking to attorneys is not like talking to other doctors. They go to school to manipulate, to get the answer they want, to make their case. And some of them are very, very good at it. That's what they do, right? So it is their world. It is not your world. And the other thing you're told right away is you can't talk to anybody. Well, wait a second. You've never had the situation before. You're in a legal suit that could cost millions of dollars. Your reputation is at stake, and you can't talk to anybody about it. And everybody is fearful to do it. And there's a lot of things that we can talk about that there is help for people that you can talk to navigate it. To those of us that have been through it and know what questions you're going to get asked and how to respond to it.
I can't help but chuckle to myself a little bit on the way that you describe the attorneys. Master. They
I mean, yeah, there are textbooks written, just like textbooks of surgery, how to get the answer that you want, even if the doctor does everything right. I mean, but that's their goal. The goal for them is to win at any cost, right? If they're the defense attorney, it's the win. Whether you did something wrong or not, their goal, they're going to help you win, right? Even if there's you left a lap pad in the belly, that's not defensible. Believe it or not, I have defended a surgeon and he won that left a lap pad in the belly. Okay. So they're the defense side, they're there to defend you. They will pull out all the stops. If they can win on a technicality, they will do it. Same thing for the plaintiff side. And the other thing you have to remember, most 90% of medical malpractice cases in this country, 90% settle out of court, whether you want to or not. You, as the doctor, don't have a lot of say of settle or not. You don't have a lot of say. You sign something with your malpractice carrier. They may say, look, it's cheaper for us to settle. It's expensive to go through a medical legal case. You have to hire experts. You got to do depositions. I'm doing a deposition later today. All the attorneys are flying to Richmond. Somebody's paying for that, right? So there's a lot of different things that if you're not involved or know what you're getting into, getting help on the beginning would make a big difference and goes a long way.
Yeah, you need a good legal team, and I will call attention to our experts for doctors directory, where there are already two attorneys there, and I'm sure there are plenty more that are going to eventually get added there. Now, trust and communication emerge as key themes in your article. How did the lawsuits influence the way that you engage with patients and families afterwards? I think you actually responded to that in that you're much more vigilant in your conversations, correct?
Yeah, and that's a good point to bring up again, though. I don't, by the time you graduate as a chief resident, you start your practice, you feel like you're invincible. You can do everything. You haven't seen a lot of complications. Complications were the attending's fault, right? You were the resident. But then you start and now you're making the decision. You see the patient first. You um, not convince them, but you encourage them that they need surgery for whatever reason it is. They've had multiple bouts of diverticulitis. Yes, you need surgery, but over the years, I'm much more um, serious with them. Now, that's not a great term to use. Explaining what the potential complications are. In the best of hands, anybody that does your colectomy, me or not, this is going to leak and fall apart 7 to 10% of the time. Some patients don't want to take that risk. Some patients say 10% is not that high. I think that's kind of high. But remember, outcome of your surgery is irrelevant in standard of care. And I'm going to say that again, because all doctors think if they have a complication, it's their fault. Well, you can't foresee what's going to happen. I don't have a crystal ball. I can't look at this case backwards. If I do a colectomy, 7 to 10% of the time, it is going to leak. Most lawsuits that I'm involved in and asking to opine on standard of care, it's not the complication that gets the provider in trouble. It's the failure to recognize the complication and the delay in recognition that then caused harm. I don't care if you have a colonoscopy perforation, that's going to happen. But did you recognize it at the right time? Did you ignore the white count that went up from 10 to 15 to 25 for 3 days and the patient screaming in pain? You didn't do anything. That's the problem. So delay in recognition of complication. I am much more quick now to act on anything if the patient is not progressing normally, either imaging, CAT scan, or look in there with a scope. With laparoscopy now, remember, this is 30 years ago, we didn't have this laparoscopy. It's much easier. The risk is a lot less for me to say, listen, you're not progressing normally. I need to make sure you don't have this complication, which could be a leak. If I miss it, you die. They usually will say, doctor, thank you for taking care of me. Nobody faults you for a negative laparotomy, right? If I think it's a leak, if I think you have dead bowel and it's negative, patients are happy, right? So it's the failure to recognize, I think, and I'm much more quicker to act now than I was 30 years ago.
Great advice. So you describe rigorous preparation for litigation. What specific habits or strategies during your defense helped ground you amid that emotional chaos?
Yeah, it's a challenge. The first one's always the hardest. You never forget your first, but yeah, you have to know the case and you have to know the literature really, really well. I know. And having said that, and you're thinking, well, how would you not know the case? It's your case. Listen, nothing happens fast in the medical legal world. This is not surgery, right? You get named in a lawsuit, you may not get deposed for 2 or 3 years. You're going to remember everything that happened? There's no way. All the nuances, all the different providers that were involved, the discussions you all had, sometimes that's not documented in the chart. My one major lawsuit that settled for a high dollar amount, we had every specialty involved. All those conversations weren't in the chart, but going back to the chart, looking, trying to remember what you did and what the conversation was and how you ruled out the things that you were doing is important. Why do I say that? I've done plenty of defense cases, and the surgeon who's getting sued doesn't know that information. Listen, juries don't care if you wind up going to trial this. If you can't remember and you can't come across that you're a caring, compassionate, concerned physician, that looks bad for you. So you have to know the case. You have to know, do a literature search, why you did what you did. It's really, really important.
That makes sense. Now, let's bring in the supporting cast here. You discussed that emotional toll on families at home. How did your personal relationships evolve through the experience that you had, and what boundaries or support systems were most helpful?
Yeah. Well, certainly my partners that had gone through it before, they were very, very, very helpful. They had been through it before. So talking to them about how to deal with it, I was very cranky. You can ask my wife. I was mean to everybody, not on purpose, but it's it does take an emotional toll. Getting help, and there is help out there now that I didn't have 30 years ago. And let me give a shout out to one of the members of SOMI Docs, Dr. Geeta Pensa. She has given a lecture on this. She is fantastic. She actually stole my idea. No, she didn't steal my idea. I always, I'll tell you, because I talked to her about this, but she's a fantastic resource if you're going through something. Um, she has a business model to help physicians that are getting sued to do the things that I'm talking about because it's an unknown, right? But I've done enough defense work, and sometimes what the surgeon or the provider will say under oath hurts them at trial. Let me give you an example. The last case I tried to defend, the surgeon did nothing wrong, bad outcome, not related to standard of care. However, the very last question that he was asked on deposition by a very smart plaintiff attorney said, Doctor, knowing what you know now, would you have done something different? And the answer was yes. That is not the right answer. What do you mean, knowing what you know now? You're looking at this case retrospectively. The better answer would be I'm not looking at this case in retrospect, but based on one, two, and three, the information I had about this patient, the surgery I wanted to perform, the medical issues he prevented, I met standard of care. I couldn't, this is not a preventable outcome. That's a better answer. The jury found against the doctor because that last word on his deposition. And that drives me crazy. Right. So, and he didn't know. He was being honest. Sure, retrospect, I would have done something different. We all would do something different in retrospect. That's not what you're asked. Outcome is irrelevant in standard of care. And doctor, so I had thought that this would be a great business model to teach other doctors about attorneys. Dr. Pensa is way ahead of me. So anybody listening, she's a great resource. You can find her on SoMe Docs, and she's very helpful.
Amazing. You can go to our doctor directory and literally just plug in her name, but I'll also plug that she's going to be a speaker in the lineup for our second annual private practice conference. Her talk is titled "You've Been Served, Now What?" And she's
Right.
going to teach you the very first steps to do and some crucial steps to avoid in the early days of litigation. So thank you for plugging her. I'm sure she'd be appreciative of that. Now, you recommend seeking peer support as well from colleagues who have been through litigation. What qualities made one colleague support more impactful than another?
Yeah, that's a good question. I mean, I think the colleague that made the most impact was really my senior partner, who had been doing this for 20 years before I even started. He's retired now, but it's much easier to talk to somebody who's already gone through it that's not emotionally involved, because most of us, when you get called on that they said you did something wrong, I'm going to fight back and I'm going to yell and scream, right? But that doesn't help, right? Juries can see that. A lot of times these depositions are videotaped. They can see your body language. They can see, they can tell. So talking to my senior partner who had been through it on several occasions and he had won all of his cases, he took the emotionality out of it for me and he just sat down and talked to me through what was the case. Tell me about the case. What were you thinking? What did you do? Right. We went through the data. We went through some of that information. That was helpful because I could see it from his point of view. That's why having somebody who's not emotionally involved in the care of that particular patient will help guide you. And he did some question and answer. He goes, okay, you did this. Well, what if the attorney asks you this question? How are you going to respond to that? Right. And I would yell, no, that's not how you answer that. This is how you should answer it. So that was very helpful because I didn't know.
Okay, before we go into the last question, these are all such useful pieces of advice. Before we go into the last question, I am going to now plug you because you've been really wonderful in joining us and in writing articles and hopping onto episodes. I do want to plug that you're going to also be a speaker in two of our upcoming conferences. And regardless of when you see this episode, if the conference has passed in its live version, it becomes a course you could still access. But you're speaking in the first annual investing conference that we have, and your talk is going to be finances for young physicians. How exciting is that? And then the second talk you're giving is prescribing posterity, diversifying income for a resilient medical career. That's at the second annual entrepreneurship conference. So super excited about having you involved in those. Let's go into that last question, which I think is a great one to hear what you have to say on. You note that medical defenses often avoid apologies, yet you advocate for candidness. Was there a lawsuit where an open apology fundamentally changed the outcome for better or for worse?
Yeah, I mean, I think the very first. So I've had 5 lawsuits, and they're in the article that you'll all read. The first one and the last one were dropped, and there is no doubt that in both of those cases, the apology helped. The first one was a central line that somebody left the wire in. It wasn't me. I didn't put the central line in. The patient liked me, and remember when I said that the patients don't want to normally sue you? It's a family member when the patient, that first patient, 6 months after she filed the lawsuit, or when the attorney filed the lawsuit, she called the office to try to make an appointment. Well, her chart is flagged in our system that she's suing the practice and Dr. Cohen. And the practice manager gets on the phone and says, you can't see Dr. Cohen. You're suing Dr. Cohen. And she said, quote, I'm not suing Dr. Cohen. I love Dr. Cohen. Right. So, it was a central line that anesthesia put in during my surgery. I had nothing to do with it. But certainly I followed her. I arranged to get the wire out. She had no sequelae from the wire. I certainly apologized to her and to the family that happened to her. But again, it was the family that drove the lawsuit, not the patient. But that definitely, no matter what you'll say, I think personally that makes a difference at apologizing for the complication, because some of the complications that I've caused and that you may cause, doctors cause, are life changing for the patient. And you have to remember that. They didn't expect to wear a bag and poop in a bag the rest of their life. But because of that leak, which is a known complication, they have to do that. So you have to remember, you know, and I tell this to the residents all the time, and I know it sounds silly, but having seen my parents, doctors, I've been a patient myself, or my parents being patients, how do you want your mother or your father to be treated? Right? If you look at it through that lens, you'll be a little bit more empathetic to the problems, even if it's a preventable outcome, which most of them are. You'll be a little more empathetic and more caring. And I think that's the best way to prevent medical legal action.
Well, there you go. Apologies dissected and also just a beautiful approach to caregiving. So, Dr. Cohen, thank you for joining us on yet another episode, and we look forward to your participation in the conferences as well.
Thank you so much.